But I think it might be time to move on to the next thing. And we're going to start the next session with patients. And I'll try to keep it quick because some of the issues have already come up. So let me the patients can come up.
Hi, yes.
Hey, and the brain is not working right now. And Anna and Cappy and Leah. Yes. Hi. So Zuli, we'll start with you. And your child, once again, is one of those, in between SJIA and MAS, correct?
Yes, correct.
And we've put up the stories here so that, you guys can just read up the stories quickly. But I think it's worth kind of pointing out that for your disease, you've actually started Gamifant, yeah? Why don't you just talk about that? So like you started JAK inhibitor and that helped. And then what happened?
Yes, we started Gamifant over a year now because she's been on every biologic and she's failed them. Then we had to do stack medication. She was an Ilaris and Celgin. But then after like about 8 months or 9 months, she started to decline again. And what we used to do is do IV steroids, to control the flares. Well, the last one, she ended up having an anaphylactic reaction to IV steroids. So this is when we decided that it was time to get Gamifant on board because we were almost running out of options, especially since steroids is usually the first phase of controlling a flare. Once she started Gamifant, it started to help. It did. Her liver numbers started to get much, much better. That now her liver is considered to be in remission. When once we had a conversation of maybe having to do liver transplant because we didn't know what was happening to her liver. It wasn't getting better. Every treatment she was failing, and so I'm very grateful that I was able to get her team on board to get Gamifant.
Got it. And but you still see flares of SJIA, yeah? You continue to see that.
She's had 2 flares since she's been on Gamifant. She had one in the summer caused by a virus, and thankfully we were able to control it and things got better. This time she just had another flare due to a vaccine, and it was a little harder to control. And that kind of scared me because I had not seen her in so much pain since onset. And because we don't have IV steroids available, it makes things much difficult. And we had stopped the Ilaris back in May because she had gotten much, much better. But we had to give her Ilaris this time, and thankfully it helped. We don't know yet if we're going to go back on it or not. We are going to find out in a couple of weeks. But this is where we kind of stuck with her. Her liver, it is much better. But of course, my concern is if she continues to have SJIA flares, where would that lead us? What can her liver get damaged again? That's my worry. And especially she has extremely high IL-18s. They've reached the 400,000 more than once, with LDH in over the 8,000s. Now with Gamifant, her IL-18 has gone down to 8,000. It goes between 8,000 to 15,000. But when she has had the SJIA flares, it's gone up to 80,000. This time was up to over 30,000. So that IL-18, when she feels unwell, it goes up. And when she starts to feel better, it goes down.
Got it. Understood. So all goes up with SJIA, but you don't see the typical MAS patterns anymore.
Yes.
Yeah.
Yes.
Okay. We'll move on to Anna, whose story is of severe lung disease, which started and proceeded really fast. I'm just going to quickly, Anna, do you want to talk a little bit about, the last 2-3 years after the big sick?
Sure. As Rashmi mentioned, my daughter is a lung kid. She had a really rough start and declined really quickly with her lung function, and is now a trach, vent, oxygen, G-tube, heavily medicated kid trying to take care of that. But in the years since her lung issues began, she's fairly stable. She has a lot of issues with infections, obviously, because she's highly immune suppressed and lots of hospital visits, requiring lots of oxygen and ventilator support. One thing I think is a little interesting with her is that a lot of these lung kids, you hear about signs before you actually see symptoms on CTs with clubbing. Her clubbing didn't come until probably a year or so after her lung issues began. So she's a little wonky that way. We follow her with CTs very frequently. I image a lot. We do twice a year to keep track, because for me, that helps guide her plan of care. Her last CT in the fall was the first that she's really ever had that she's stable. And it actually showed that she had improved a little bit on her left upper lobes, which has never obviously happened either. And I don't know if it's just we finally found the right stacking of meds. You can see kind of at the bottom of the slide, she's heavily medicated, but I don't know if it was the addition of the IVIG that finally found her the sweet spot. She has, you can see on the slide as well, the damage that she has to her lungs. She has extensive thickening. She has ground glass. She has cysts everywhere. She has pockets of little collapsed pieces. And from this last CT, which was kind of the hard piece to hear, is that she has zero area of healthy, normal lung tissue. It's all damaged in there. So for her, that is her biggest issue. And right now we're dealing with a little bit of, I don't know, the investigation game of, is she having some more SJIA lung issues? Is it a gift from COVID? She had COVID in January, and she's having really high heart rate issues, oxygen desats, breathing really quickly. Is this the start of pulmonary hypertension? So we're adding a cardiologist into her mix. She's 6 years old now. This all started when she's 1, and we decided this year to send her to kindergarten, even though she's a highly immune suppressed kid and needs a lot of help, but she goes to school with a nurse and she really is enjoying it.
Yeah, it's it's a tough story, but I think Sophia has been amazingly, so much better in the last few years. Mm-hmm. Yeah, it's a real come around. Cappy, your child is an adult now, correct? Just a few days ago.
Yeah, that's a tough thing.
Yeah, so we'll kind of I think your issue has been the urticaria, yeah, and maybe subclinical MAS, but not overt MAS.
Exactly. So he was 14 when he presented with symptoms of chronic hives, and so that sort of waxed and waned for about 16 months. And then his disease really ramped up quickly after that 16-month period. So we had 2 ER visits after that. And after a heavy exercise bout, he was training for a half marathon. We think he might have had a viral infection in the middle of that. He began having daily afternoon rashes with occasional joint pain. And then by mid-January, he had an elevated CRP, fever, rash, itching, joint pain of the hands, wrists, and knees. 2 weeks later, 2 more visits to the ER, and he had a 3-day stay in the hospital. And so it wasn't until the day after his discharge that he was diagnosed with SJIA. So he's been on methotrexate, atrema, Alaris, cyclosporin, and tacrolimus. His Kineret was at one time bumped all the way up to 300 milligrams twice a day. Kineret, tacrolimus, and steroids were used. He saw a mast cell specialist. We went through all of the mast cell drugs. And he's currently on 300 milligrams of Kineret, Xeljanz, steroids, and the gabapentin is helping with the chronic urticaria. But as Rashmi mentioned, he's had 3 to 4 bouts of sort of subclinical MAS whenever we tried to taper his steroids. 17 seems to be his tipping point. He's had 2 IL-18 labs done, and they hang out at around 32,000. This is a kid who, before this diagnosis, had 1 inner ear infection his entire life. And this Christmas, he actually had to text me to bring him his Kineret because he couldn't even sit up in bed because the day before he'd forgotten to take his Kineret and he was playing golf frisbee with his friends. So he's typically not a joint kid unless his disease is flaring. So I'm very interested in the IL-18 blockers. He would not qualify for the current trial because his onset was 14 years. And the Stills trial requires that they be 18 to 75 years. And another concern that parents have voiced is that that study has a washout period for the Kineret. And I don't know if he would stay stable if he had to get off the Kineret, because we know he has high IL-1 and we know he has high IL-18. So, the Kineret has been fairly easy to manage. We just bump that up and down with symptoms. Steroids, he's been on 20 milligrams now for about 5 or 6 years. And I just wonder if the IL-18 would help him get off the steroids.
Got it. Thanks, Cappy. Coming on to Leah, whose son also has a complex story, but we won't focus on that. Leah is just to introduce Leah, I'll stop this now. Leah actually runs and manages the SJIA family Facebook group, which is now, as she pointed out, 1,800 patients. And she personally, the group is not just open. You actually have to say who you are and your case a little bit. So Leah has the honor of going through every person who applies and reading a little bit about their story. So Leah, do you want to quickly talk about how the group has changed? How earlier we used to have a lot of refractory patients and now people just come in on day one of their diagnosis?
Sure. And not just day one. Caitlin is also in here and she has came on as a moderator because it has just grown to be too much for one person. But we often have people who are hearing about our group while in the hospital before they even get an official diagnosis from doctors or searches online. So the group has definitely changed over time. We talk about this, especially as refractory patients whose kids have been diagnosed for a long period of time, how the group used to be very much almost like daily updates and kind of chatting about how our kids are doing from day to day or flare to flare. And now there's a lot of questions about drug use, also questions about trials that are coming up because patients are being given the opportunity to start a trial, but their child is very, very sick and they don't know whether they want to take a drug they can get immediate access to, or if they want to wait and do the washout period or put their kid into a trial where they may not get relief when they've heard such good things about their medications. So yeah, the group, I said earlier in a comment, is around 1,800 parents currently. I think we're representing around 1,400 patients worldwide, with our biggest groups being in English-speaking countries like the US, Canada, Australia, England. But we do have patients from around 100 countries. Some of those are only one patient or two patients, but those patients also represent centers at times, and they take that information back to their teams to share with other specialists. So happy to answer any of the questions you may have, but for me personally, and I've heard this from a lot of people, it's been the best place to find not only support, but being able to really identify kids that are very similar to your child. And I hate to say predict, but almost predict sometimes what's going to be coming up next. For my child personally, we have an amazing team for him, but it has been a lifesaver. Literally has saved his life in one situation where I became aware of a reaction and aware of other medications that could help and was able to take that back to my team. So it's been a vital part of his journey. I think many other kids as well.
Yeah. And what Leah alluded to briefly there was that something we noticed is that there are trials, but the current trials in SJIA, but I think there is a dilemma in patients, being able to get those drugs without the trials, or they have a bunch of options. The trials that the patients they are directed at are often not interested in those trials. So there's an interesting dilemma going on in SJIA right now. And I think that trials need to account for the kind of the end patient experience regarding that. But anyway, I know we are running kind of short of time. So I want to move on to the next part and hand it over to Hermine Brunner for the next part.
Can I add something very quickly, Rashmi? Just very quick.
Yes, yeah.
So one thing as a community that we really push too is that we're doing work for all of our kids. It's not just one. So, I may not do something that's just perfect for Ezra, but I know that the outcome may help other kids. And that's very hard, especially in those early moments of diagnosis, to see that this is a rare disease And sometimes the decision to join a trial, even when it isn't an immediate response, in the long run benefits all of our children. So that is a discussion we have really frequently in the group, is how do we not only help one child or one subset, but everyone as a whole?
Yeah, absolutely. I would say that the long-term patients often are very big supporters of trials, and we try to like push them. Sometimes it's a little bit difficult, but yeah, absolutely. Thanks. Over to Hermine now.
Well, thank you for letting me moderate. My name is Hermine Brunner. I'm a pediatric rheumatologist in Cincinnati, working with Alexi Crum, and I know very well Fabrizio DeBenedetti and some of the other experts today on this meeting. If I'm not mistaken, Fabrizio, you're going to show some slides. Is that correct?
This presentation is about including or thinking about clinical trial in refractory SJIA, which is exactly what we have heard about, a spectrum of patients with very acute or very smoldering disease with or without lung involvement. And I'll take the liberty to cut and paste from a slide that Alexi showed yesterday with the 4 phenotype that we can recognize of refractory SJIA. So what is the situation now? And you've been outlining this pretty clearly in the last few minutes. The vast majority of patients respond to IL-1 and IL-6 blocking agents, but 15 to 20% do not. They're usually persistently active. They may have very acute episodes. They require long-term therapy, and usually glucocorticoids are always there, which is a problem, as you well know, as parents, and we know as physicians. And we try as physicians a pragmatic approach by trial and error, trying different drugs, either approved or off-label drugs. Now, there are a number of standard trials for standard SJIA patients, let's say the non-refractory ones, okay? And these trials have difficulties in recruitment, and I understand why. And some of the reasons are listed here and have been mentioned in the last couple of hours, talking about the difficulties in being into clinical trials. And so I understand why these trials are difficult. So ideally, one may think the trial should be done only in these patients. And we have discussed that this may not be exactly the case, and we might have subgroups, but let's try to go through the different phenotypes. So my take is that the refractory SJIA with persistent arthritis have SJIA. They have classical SJIA, they meet the ILR criteria. They are mostly eligible for the ongoing trials with new drugs that are being tested at present. To the best of my knowledge, these 2, in children at least. These 3 actually drugs shown here. However, if you want to think about trials of new drug for the standard patient, then for the non-standard patient, the refractory ones with persistent arthritis, these are the issues that are open to me. We should lump together children and adults. If it is a new mechanism of action, I personally would favor the approach of starting 12 years and older, and then do some PK modeling for your younger kids. There might be an issue with sample size. There is certainly an issue with randomization versus open label, but one could think about randomized over standard of care, with standard of care, or doing just open label trial with external controls. And this is something we need to decide. The next group of people are the other ones that I think should be lumped together. They are predominantly systemics, they have little if any arthritis, they're largely overlapping. Most of them have high IL-18 levels. I think we have heard this. And importantly, and this has been noted in the last couple of days, those patients without arthritis won't meet eligibility criteria for the ongoing clinical trials. So the relapsing MAS, some of them do qualify for the ongoing MAS trials. They have the same pathogenic pathway of the classic acute MAS that Alexi alluded in his presentation, and they have been included in recent mass trials. The outcome is MAS remissions, but not necessarily the underlying SJIA, and this has been again noticed today. Some of these patients may require longer treatment compared to patients with acute classic MAS. Think about the liver involvement. But other than that, I think that this is a one continuum of rather homogeneous patients with just different clinical phenotype. So if we were thinking about a trial in this patient, let's assume on IL-18 thing, whatever that is, we would not necessarily use the ILA criteria. We would use something else. I like the CARA, which is not listed on the slides, by the way. The adapted ILA without arthritis, without the duration of arthritis, looks also fine to me. The Printo provisional looks fine to me. The Yamaguchi would have the advantage to allow to include adults, but adults with these phenotypes are not very frequent. So I think we should stick to pediatrics here, to children. With or without ILD, with or without relapsing MAS, we will need post-hoc analysis or subgroup analysis, better say subgroup analysis for this subgroup of patients. They have to have failed IL-1 or IL-6 inhibitor. And I think there are enough data in several labs around the world, largely superimposable, that we might be able to come up with what is a decent, acceptable cutoff for IL-18. And I will urge Scott to do so. The outcome for such a study, the ACR responses are not suitable. IL-18 cannot be used nor as a PD marker, neither as an outcome measure. And I want to stress this because it was discussed yesterday, cannot be used because it's the available monoclonals probably will mess up with the ELISA assay, the immunoassay used to measure IL-18. So I don't think we should use IL-18. Now, there is an outcome measure that was developed a couple of years ago, which is systemic JADAS, that takes into account, in addition to the arthritis component that is part of the JADAS anyway, also the systemic features. We can go through that, and I have a couple of slides, but I think for the sake of time, I will skip those. There are functional tests for ILD. Some of them are listed here. The CT scan, I should have put a question mark here because I don't think we have a way to really quantify interstitial lung disease by CT scan yet. Mass remission is fine, and it's applicable to those patients with clinical or subclinical relapsing MAS in the group. I'll skip the systemic manifestation score. Part of it, we can discuss it, but I think it's a tool that might be very useful in this particular population. How do we design such a study? Now, I think the context and the concept of IL-18opathies is gaining more and more evidence supporting it. So I like the idea of a basket design here, and this would be the proposal, brutal. A basket design, sequential in the context, designing different baskets. It cannot be a randomized study. This has to be open label. The number of patients in each basket may be very small, may not even get into the double digits number. So for this, we would need external controls, and we would need natural history studies that are going to be discussed later. And I think this is my last slide. And I've just used those slides as a stimulus for the discussion. Hermine, to you. Thanks.
Thank you, Fabrizio. Lots of food for thought. I was looking in the chat whether there were comments. I couldn't detect any, but let me look again. You had proposed in the end that a basket trial with open label treatment seemed to be the best, from your point of view as an expert, the best approach. Now, how would you then counter that? How would we assess treatment effect if you give open label study, open label medication?
I think external controls are the ones that we should use. And I don't see any other way around it. And if anybody sees it, I'll be pleased to accept it. But I guess these are so rare patients, and I see Nikolay coming up, which is great. So Nikolay.
I don't think I have the answer to your question. I think my question would be the same as Hermine's, which is, how are you going to demonstrate the efficacy in an open label trial?
N of 1 internal controls, but I don't think this is going to be easy to do. But I guess that external control in a natural history study is is the best way to do it. These patients are relatively rare, no, very rare, I should say.
Yeah. So let me, I like the idea of maybe adding on at least the older pediatric patient to studies that have been, because of the rarity of the disease, are also offered to adults. One would expect that the PK and the immunology of a child is very similar to that of an adult, not a very young child, but an older child. So if one would accept a short placebo exposure possibly for the older children, couldn't then the younger children just get open label medicine? Because in essence, you would already have shown the effect of the medication in the older children.
No, I see your point I think this is very applicable to refractory SJIA with persistent arthritis. I don't see this applicable to the basket of stuff that is associated with IL-18, with lung disease and relapsing MAS, because I think these phenotypes are not known in adults. And it's an issue of very young children. Usually these kids have very young disease, very young age of onset. So it's okay for the persistent arthritis group, but the others, they do require a pediatric only trial.
You think it's pediatric only because the phenotypes are so severe that you wouldn't even see it very common in an adult patient unless they were very aggressively and very well treated as children. Is that what you think?
Yes, you don't see IL. I mean, you see very little interstitial lung disease in adults. Relapsing MAS is very rare. Well, I mean, interstitial lung disease in the context of still disease. Mm-hmm. It's not described. It's my understanding that it's very rare.
Okay. So the term basket trial you're using is to describe the different phenotypes of these diseases, autoinflammatory diseases that are governed by high IL-18 levels. And you can have gut disease, lung disease, liver disease, and probably some other diseases we haven't really realized. So the issue of control comes. Alexei, do you have an answer to that?
To me, sort of, if you look at these patients, and we just heard of quite a few stories, right? They all are on tons of medications, and sort of they remain on those medications continuously. And we can come up with some kind of a natural history study, sort of specifically look into that, right? Mm-hmm. And then if we start a drug, and if suddenly we are able to reduce those medications, isn't it convincing enough, Nikolay? Can you comment on that?
So I guess what you're suggesting is that changing all the treatments to be used as an endpoint in clinical trials.
Well, reducing
right.
The medications, and that's what we heard in the stories, right? So those patients would start with an enormous amount of drugs, would remain on those drugs forever. And then suddenly with the treatment, we could suddenly decrease the drugs and discontinue many of them.
So I guess you're discontinuing these drugs based on clinical evaluation that the patient is getting better or stable.
Correct.
So,
and we can come up with the criteria for that, correct?
So I think the bottom line is that you're assessing still a clinical benefit to know that there is a benefit of this intervention to allow you to, manage all the treatments, right? So I think that's really the key here. And how do you make this decision? I think it's something that, would be considered more clinically relevant than stopping the other medications. So just to give you an example, we recognize the importance of decreasing toxicity of some medications, including steroids, for example. And we have considered this to be an supportive evidence of efficacy when you have primary endpoints based on clinical outcomes. For example, in lupus trials, we have used clinical outcomes as the primary endpoint, and then describing the reduced use of steroids as sort of a tangible additional clinical benefit. I'm not sure that we would base a decision solely on changing all the treatments. I think that's sort of a framework that's kind of difficult maybe to understand, but I think what we're looking for is the benefit to the patient in terms of their disease activity.
Even if it's steroids, even if we manage to decrease steroids, and we show that in the historic control group, it's impossible to taper steroids in that population.
Well, so let me ask you this question. Do we know how much steroids, how long steroids should be used for these patients? I think the challenge with kind of decreasing steroids is that we don't really know what is the relative contribution of, we don't even know what doses and what duration of steroid use is needed for these patients. This is really the challenge. If we had a specific dose that's used for these, by these patients for controlling their disease, and you can show that you can decrease it, that could inform, the efficacy. Now, if we're talking about complete withdrawal and stopping of steroids, that's easier to interpret than, reducing of other treatments. And again, you're reducing them because you are impacting the disease itself. And what we would like to have is, how do you assess this impact on the disease itself so that you can, manage other treatments? I don't disagree that the effect could be measured, or effect could be measured by the effect of other treatments, or changes of other treatments, but it's really the clinical impact on the disease that you're interested in. And maybe I should also reframe it. So if the intent is to taper or not use toxic drugs, like the objective of the study would be to reduce the safety consequence or the toxicity of other treatments, not so much the effect of your drug on the disease. And that's not really what we're looking for. We're looking for the clinical benefit to the patient. And then whether you can discontinue toxic treatments, that's potentially another benefit. I don't know if I made it more complicated, but I think what we're looking for is really the effect of a treatment on a clinical benefit, clinical outcome, whether that's mortality, which would be, a hard endpoint, especially if you use historical control. We really need to have a reliable endpoint that we can compare the results of treatment to that historical control, or some other clinical benefit that you can, demonstrate. I think that's really, I don't know if that makes sense, and I don't know if I made it clear or more complicated.
It does make sense.
What you're saying is that the steroid decrease is a proxy for some other disease feature, like improved IL-18 measures, lower ESR. And so why not measuring the direct outcome, but going the indirect route? I see that Rashmi had a comment.
I actually, I think it's a slightly different comment, but I think this is, there has to be a way we can define it, because if you think of the stories, the quality of life improved, patients, kids were able to start going to school, because once you're not on 10 immunosuppressives and your immunosuppression is not so high, then you can take all these risks. So I think I'm trying to think of, maybe there are disease analogs where we can find these kind of measures, but there is definitely improvement in quality of life. I wanted to come back to the inclusion criteria and, how to define the disease for a minute. And, I work in a lot of other rare diseases, the ultra rare diseases, which are genetically often defined. But there's a real moment going on in ultra rare disease trials, where people are being able to take really small trial designs and go with it and try these genetic therapy type of things. And even in rheumatology, we see NLRC4 mutation type diseases, which are really small. And can't we see things like SJIA, LD as it's similar to that? They're not genetically defined, but there's a strong phenotype. There is a biomarker we have. Can't we do trials similar to the NLRC4 mutation type trials?
So, I think I'll be careful about what I say,
Okay.
But I think generalizing experience from other diseases or other programs, is a good idea, but sometimes the devil might be in the detail. And just to give you sort of a context, you can take a look at the approval of the DIRA or anakinra and rilonacept, I think, for DIRA, which is the deficiency of IL-1 receptor antagonist, which is a very rare condition. However, that's a disease with very well understood genetic underpinning, and the intervention is really in the pathogenic, essentially a replacement treatment. So the evidence and the natural history of that condition was also very well characterized, sufficiently enough to use the data from an open label study to compare and use to make conclusions. And the study was done in less than 10 patients or so. So I think this is the context where we have sufficient information to make these calls. For diseases that are a lot more complex, like inflammatory diseases, and that includes SJIA, where they're not single monogenic diseases, and the interventions are immunomodulation, immunosuppression. I think it's very hard for us to have the same level of confidence the way we do with these monogenic diseases like DIRA. So it's good to learn from those experiences. I'm not sure that they would be applicable to SJIA specifically, or to other more complex diseases. I think at the end of the day, we need to have a very good understanding of how the drug works, first whether it works and how it works, to be able to weigh the potential risks of a new treatment. And how to get to that point, I think it's the most challenging part, particularly when placebo or placebo control is not an option.
Understood. I understand the problem with less well-defined diseases like this. But when it comes to the risk-benefit ratio, I think this is where, how do we as a patient group kind of articulate the risk-benefit ratio? Because as you can clearly see that the parents, they kind of have to take the risks because the other options are worse. So and I think this is, how do we do that? Is this a patient-focused drug development meeting where a bunch of patients do articulate the risks, write it down?
So I think to put this in the context of the benefit risk assessment, we need to understand what the benefit is, to consider what the risks are. And if patients are willing to take any risk, including dying from a drug, that's not really how we assess this benefit risk. We really need to understand whether a drug works, because that could, a drug that's not adequately assessed could provide sort of false promise or hope to patients.
Yeah.
Without well, Fabrizio has a take on this, but I think this benefit risk assessment will certainly consider the context, which is a very rare condition with highly unmet needs, with potential, serious consequences. We get that.
So it's pretty clear. What was Nikolay saying to us clinicians and to you parents means that we need to find a way to measure the clinical benefit. In addition to, taking risks, which, as Nikolay said, are in the context of a severe, life-threatening chronic conditions with a very severe impact on quality of life. This we know, okay? And so when we evaluate the benefit, we take into account the consequences, okay? But the benefit has to be measured clinically. And there are ways to do that. Either physician global or parents globals are variables that are being used in several trials, okay, with some objective measure of inflammation. Mention the simplest one you can think of, CRP, okay?
Yeah. I was just thinking.
Ferritin in the context. So I think we have to come up with a composite way of measuring this, okay? Disease activity. And I think that in this context, tapering of drugs is very important. It's a very hard measure of efficacy. The point is that in the regulated world of clinical trials, there has to be a primary outcome. This is my understanding. And unless Nikolay wants to challenge this, there has to be a primary outcome statement. I think that there has to be a primary outcome, and we have to come up with something that makes sense.
Fabrizio, while you were talking, could the community come up with a highly specific biomarker or composite biomarker? Would that be something where you could show response to therapy, beyond the physician global and the patient global? And we know that IL-18 is not a biomarker, but CRP and ferritin, maybe if you look it together, or even
CRP and ferritin,
for lung patient, BAL results.
My guess are CRP and ferritin. BAL is a bit complicated. I think it's a little variable. Alexei knows more.
Yeah, we need to be careful because the CRP certainly is not a reliable biomarker in patients treated with tocilizumab. My very limited experience with the IL-18 blocking agents suggests that even ferritin may behave differently in that population. So when it comes to biomarkers, we need to be careful. We need to have more data and confirm that they are reliable biomarkers.
I don't see any more arms up, but Nikolay, any more comments? I would like to hear more comments to the N of 1. Thinking about it longer, the patient seems to be, the best own control. So if you really delineated their disease course, and that could be actually captured in a prospective cohort, couldn't you use that information and the ability to taper steroid during the pre-treatment time as an outcome or a way to show effectiveness?
So, I don't think I can comment on this proposal specifically. So I think at the end of the day, we need to make decisions on the population level or sort of the larger group. For individual patients, we have certainly made calls to allow investigational drugs to be used for patients who are, in those dire situations. So on an individual patient level benefit risk assessment, we have made these calls. I think at the end of the day, for us, it's important to be able to make this call for the broader group, for the population. And this is where, we need to have confidence in the data. And I noticed that there were a couple of comments in the chat about kind of how to frame and how to think about this issue, about having confidence about the effect of a treatment versus having something just to feel good enough.
Additional comments about the usefulness of CRP and ferritin. I think whatever biomarker we consider, we need to use this 80-20 principle, that it works in most patients, because I think in rheumatology, you can always come up with a one patient where a certain measure or certain lab test just doesn't work well.
I think maybe we should wrap up the discussion. Hermine, is there any other questions, points? Okay. So it's not too bad. We went 13 minutes into a 30-minute break. So we'll wrap up right now, and then we'll be back at 10:30 for the discussion about external controls. We'll be continuing this, but kind of getting into the specific questions of the external controls. Thanks, everyone.